Thank you for those words. I'm Frank Brown. I'm just a board member of this organization for the last 25 years or so, and have the privilege of introducing some of our speakers this morning. So this as you may know, those of you that have been here before, we typically have this a potpourri of different topics, and these topics are actually chosen from what you have recommended in the past, what attendees have recommended. So first presenter is Dr. Josh Hansen. Many of you may know him. Josh is from here. He's from Ogden and went to Weber State and then went to medical school at the University of Utah and was a graduate of our program here in family medicine, and then headed out to the Midwest and went to Oklahoma for a year for his fellowship in sports medicine. He's come back to the area. He works over at Tanner Clinic, and his topic is a topic that kind of gives me headaches over the years, and that is concussion management and what to do about that. So he's going to talk about the new guidelines for concussion management. So please welcome Dr. Hansen to the podium.
All right, figure out my little clicker here. Appreciate that. I'm excited for the opportunity to be back here and be speaking. I spoke in the conference years ago doing a poster presentation as a resident, and so kind of full circle coming back here and presenting on concussions. Let's see. Is it? Oh, pushed the wrong button. There we go. Okay, so I have no financial disclosures. My objective is pretty simple. I don't want to get lost in the nitty-gritty of any non-clinical research going on in concussions. I think there's a negative stigma around concussions, and a lot of providers will see a concussion on their schedule and their heart drops for the rest of the day. And I want to try to alleviate that a little bit and just talk really the basics of what we should be doing for concussion management. So to start off with, I have a little clip here to get, it's one of my favorite comedians. His name is Nate Bargatze. He talks just quickly about his experience with concussions. So hopefully the volume and things will work on this.
And I would get over a railing and just fall 6 feet to the ground. And just land, you don't catch yourself, it's just whatever hits first. All your body weight just lands on your head. I got a full-blown concussion. I'm crying. My parents are like, just go back to a deep sleep for 7 hours. I've had 3 concussions in my life, and none of them because of sports. Just living life, man, you know? Stuff happens to your head. What are you gonna do? One was in high school. I got pushed into a wall head first, and it took them 3 class periods to figure out I had a concussion. That's how much I was bringing to the table. 2 teachers didn't even notice, and the third one was like, he wasn't facing forward, and that's when I realized he's one of the better facer forwards I've ever had. So I knew.
Awesome.
I remember I would fall out of a bunk bed.
So a big part of this is concussions are not just sports concussions, not even predominantly sports concussions. As Nate Bargatze said here, he's had 3 concussions in his life, none of them from sports, just living life. Stuff happens to your head. What are you going to do? And so let's kind of talk into the numbers here. So there's an estimated about 1.7 million traumatic brain injury emergency room visits across the United States each year. About 76% of those traumatic brain injuries are mild traumatic brain injuries, which is the definition of a concussion. And it's believed that if you include outpatient clinic visits, athletic training room visits, physical therapy visits, or the concussions that just don't seek medical care, up to 3.8 million concussions per year. The leading causes of traumatic brain injuries is not sports, concussions. The CDC has a bunch of data out looking at this, and over 30% of those concussions come from falls. 17% of those come from motor vehicle accidents. Another chunk they put in blunt impact, which sports concussions would be part of that, and it's just any other cause of your head getting hit. And then 10% being from assaults. And so sports being a small subset of traumatic brain injuries. This is more data coming out from the CDC, looking at age demographics of concussions in each of those. And I want to point out a couple commonalities that we can see. There's the motor vehicle accidents, which is largely in teenage and young adults. That's why auto insurance can be significantly more expensive for that group. For falls, the young children and older adults are at the highest risk. For assault, it's the teenage to young adulthood. And then the blunt impact, which includes sports concussions, is children and young adults. But sports and sports concussions does play a large role into this. We know that tackle football is the predominant cause of concussions, and that comes from mostly tackling, followed by girls soccer as the next leading cause of concussions in sports. And that, along with many of these other sports like basketball and things, are incidental contact from athlete to athlete. And so, kind of getting into what is a concussion, we know it's a mild traumatic brain injury. It's this traumatically induced transient dysfunction of the brain. There's axonal injury, there's an energy imbalance, there's vascular and ionic and metabolic dysfunction in the brain that causes a wide variety of fairly consistent but different from patient to patient of symptoms based on this. There's been many studies that have looked at this. This is just one example of looking at a bunch of high school athletes who reported their concussion symptoms. First and foremost, headaches is the largest, most consistent symptom. 95+% of patients with concussions have headaches, followed by dizziness, some cognitive decline, light sensitivity imbalance, and many other symptoms. And so now I want to get into a little bit of what the diagnosis of concussion is. And there's a lot of research looking at different types of brain imaging, labs with biomarkers that can help us diagnose concussion. Not really ready for prime time or clinically applicable at this point. There's a lot of commercial tools available like impact and sway testing that uses computers and phones and tablets and things to help us diagnose concussions. I like to use this. This comes from a group that meets every about 5 years. It's an international group of researchers and clinicians who are kind of at the top of the game of concussion management. And they get together every 5 years and review all of the literature and come together with a consensus statement and tools to help us diagnose and treat concussions. The SCAT tool, which is a sideline concussion assessment tool, has been around for about the sixth iteration of that. And this last conference, they came out with this SCOAT, which is a clinical, in-the-clinic assessment tool of concussions for both adults and pediatric patients. And these are things that are freely and easily accessible to anybody who wants to use these in their clinic. It has some cognitive tools as well as just questionnaires on symptoms of concussions for patients. And so there's a lot of things out there available, but concussions still are largely a clinical diagnosis, looking at a history of the injury and the constellation of symptoms and a few different physical exam tools that we can use. Part of concussions that I think, and the kind of the first part of concussion management, is really setting up expectations for yourself as the provider as well as the patient. Previously, there's a lot of belief that concussions are in the days to weeks recovery range, and as more and more research has been completed in concussion management, we've seen that timeline is actually a little more prolonged for full, complete recovery from concussions than previously believed. Here's a really good study. They did a meta-analysis and looked at about 80 different publications on concussion recovery, and it had over 20,000 athletes combined in all of these studies, and they looked at return to function and return to sport. And in the majority of these, the actual median, the average time to recover was 21 days in the majority of these studies. And so I think this helps set our expectations that we don't think that 7 days most will be back to work and back to school and back to sport. It's going to be more on the 3 or even longer weeks of recovery. And then there's several factors that we're still trying to get a lot of better research data to see what other things can contribute to longer and prolonged symptom recovery. We know that previous concussions, we have a significantly higher risk of having concussions later on in life. We also know that the amount of concussions, the severity of concussions, how long it took a patient to recover from concussion, a previous concussion, directly relates with their future concussion recovery. There's some ideas and some research that younger children and older adults, that they can have a prolonged recovery. There's pretty good research that the athletes of the female sex have a few days longer recovery compared to their male counterparts. Mood disorders, things like depression and anxiety, ADHD, learning disabilities, these can correlate to prolonged symptoms, can also make diagnosis and recovery a little bit harder to follow, as concussions can make just anxiety and depression and things worse. And so is it true concussion physiology, or is it just the mood disorder and flare-up based on their head injury? Migraine headaches similarly can make the diagnosis and follow-up of concussions a little more challenging. Teasing out, is this a concussion and concussion physiology, or are they having a migraine syndromes because they got hit on the head? There's non-sports concussions, which, as I alluded to earlier on, is actually the majority of concussions. And I tried to find good research comparing sports concussions, where we have all of this research and all of this data, to some of these non-sports related concussions to see time to recovery. I couldn't find any really good data. I would say in my own practice and anecdotal evidence, I do think non-sports concussions have a slightly prolonged return to activity. I think there's a lot of psychosocial impacts with that, with trauma and stress and PTSD and things that can come from traumatic accidents and assaults and falls and things of that nature. And so more research will hopefully come from that to give us a better understanding. And then there's several things that we need to avoid during concussions to try to help limit that prolonged recovery. First and foremost, we try not to get hit on the head again. Until we have a full recovery from concussion, that is my number one teaching point to patients, is do not do anything that puts you at risk of getting hit in the head. Sometimes that can be simple things. I had a football athlete who was just on the sidelines during practice and just trying to be there to support his team, and took a stray football to the head and set him back several months from his return. And then there's this study that's kind of looking into screen times, which years and years ago, that wasn't something that we really had to worry about as much with athletes and with children who had concussions, and now that's becoming a daily thing. And even going to school, students will spend a good majority of their time staring at screens in the classroom. And so here's a study from JAMA, published in their JAMA Pediatrics. It's from one hospital that looked at athletes in the high school age who presented to the emergency department within 24 hours of having a concussion. And it randomized those athletes into two groups, either a screen-permitted group, and they just let their symptoms guide their decisions on screens, or a screen abstinence group, where for 48 hours it was recommended that they did not use any screens. And then they self-reported their success with withholding themselves from screens, as well as their symptoms throughout recovery, and this was followed by this group. And it was found that by a matter of a handful of days, those who did not use screens in that first 48 hours had a significantly decreased time to full recovery, return to school, return to sport, compared to those who were allowed to use screens at their discretion during that first 48 hours. Now, This is kind of one study. There's not a lot of studies on this, and this is from one center. It's a pretty small sample size. They ended up having just a little over 100 total participants in this study. There's no way to really placebo-blind a study like this, and then it's all subjective based on their symptoms and their reported screen time use. But gives us an idea that there's potential that, at least in that first 48-hour time frame, limiting screen use, and potentially more studies to come out on that, and potentially longer duration of limiting screen time will help in recovery from concussion. And so now I kind of want to get into the bulk of concussion management. Back in the day, concussions, it was believed that rest was the treatment for concussions. I remember in high school, I participated in sports and got concussion. I had a couple concussions. Unlike Nate Bargatze, it was not rolling off of a bunk bed. It was related to sports. And the recommendation for me at that time was essentially go sit in a dark closet, put a do not disturb sign on the door, and come out when you feel better. And we found that that's kind of the exact opposite of what we really should be doing for patients with concussions. It's more of an active recovery at this point. And so here's a really good, one of the first randomized, controlled, kind of good studies looking at this idea of active recovery from concussions. This comes from John Leddy and his group up at the University of Buffalo, and they took athletes from 13 to 18 years of age who presented to their sports medicine clinic within 10 days of a sports-related concussion. They randomized these groups into two cohorts. The first was aerobic exercise. They put them on a treadmill and had them walk on a treadmill and found out what the heart rate level was where they had symptom exacerbation. And then they had them exercise under the direction of an athletic trainer for 20 minutes a day at just below at 80% of that heart rate where they had symptoms. And then the second group was a progressive stretching program, where again they're monitored for 20 minutes a day by the athletic trainer, but they had a gentle whole body stretching program that would not have elevated their heart rate to any extent. And these groups were followed along to see their return to sport and return to activity. And the lower bar on this graph represents that group that was prescribed and given recommendations for exercise daily, and the stretching group, that top bar, and it's found that significantly by about 5 days, there was a decrease in symptom duration and a decrease in return to sport for that aerobic exercise group compared to this stretching group. And so then the same research group kind of took that data and tried to expand on it a little bit. They took two different cohorts. The cohort number 2 was that same research group and that same data that we just discussed, and they had an aerobic exercise group, and then they called this the placebo group, which was that progressive stretching group. And then they looked at some data from a similar demographic from just a few years ago, where the recommendation was rest at that time, and same age group, same kind of sports concussion, same presentation, but just a few years earlier. And they looked at that data of those patients returning to sport based on that current rest recommendation, and kind of analyzed that data against each other. And again, they found this bottom blue line is the aerobic exercise group, and the other two lines are the placebo, the progressive stretching group, and then the previously prescribed rest and recovery group. And it was again found that aerobic exercise did significantly decrease symptoms and decrease the time frame to return to sport and school. So with all that, and there's been several other studies that have come out showing that same thing, that aerobic exercise helps return to life and sport at a sooner time frame. And then it comes to how fast and how soon should we be getting athletes and patients with any kind of a concussion back to aerobic exercise. And so here was a study looking at the emergency department in kind of one location, one emergency room department that had, and they looked over a couple of year period with anyone coming in with a sports-related concussion who presented to the emergency room and presented within a 24-hour period of having a concussion. And they analyzed this data over this several-year period to see and followed these patients and their charts to see when were they prescribed exercise and what was their return to life recovery like. And this was the data that they came up with looking at all of these athletes. That red line were those who were prescribed and participated in aerobic exercise in as soon as 1 day from symptom onset and from concussion. And that solid black line at the top were those who, even up to 20 days after their concussion, they were then finally progressed to an exercise program, and found that as those groups that were prescribed and participated in exercise earlier on had a faster recovery compared to those who started it later on in the course. And so with that, we can see that potentially even as soon as 24 hours after a concussion, starting on a light aerobic exercise program can help athletes return to sport and life. And so what this is, there's a Buffalo concussion treadmill test. This was developed by that group out of the University of Buffalo. And this was a way for us to establish what's that threshold, what's that heart rate and the exertional effort that we want a patient to exercise at to not exacerbate symptoms, and that we can safely have them exercise at without making their concussion symptoms worse. And so this program was developed just for that, to establish that symptomatic threshold and help us in this treatment protocols for concussions. And so the way this is done is that we get a concussion patient and we have them at least 24 hours after they've sustained their injury. Their symptoms need to be at least 7 out of 10 or lower, so no severe symptoms. And then they can't have any other contraindication to a treadmill test. And so for those older patients, making sure that we're looking at cardiovascular and pulmonary lung disease and those kind of things that would preclude them from getting on a treadmill and doing a stress test. And then these two, the picture on the left and the picture on the right, or in the middle, excuse me, we have those taped on the wall just in front of them on the treadmill so that the patient can look at those as they undergo this test. And the protocol is they wear a heart rate monitor continuously. We put them on a treadmill and we start them walking at 3.2 miles per hour on a 0% incline. And then each minute we increase that incline by a degree until we get to a max of 15 degrees. And then after that, if they're still doing well, we then increase the speed at each minute interval. And at each of those minutes, we use that form on the top right and we ask, what are their symptoms? How hard are they working based on that middle picture? And we record their heart rate. And we stop the test when their symptoms increase by 3 or more points, when their perceived exertion gets to 17 or more, which is in the red there, they're working hard and they're feeling really uncomfortable because of how hard they're working, or they get to 90% of their age predicted heart rate, which is 220 minus their age. And at that point, we stop the test. And the benefit of this is we can look at that data and we can say, here is where their heart rate level was when their symptoms began to significantly increase. This is where their heart rate was, where their heart rate all of a sudden started to significantly increase, indicating there might be some increased sympathetic tone from concussion physiology. And we go just below that, or essentially 80% of whatever that heart rate was, and that's the line that we want them to exercise at every day for 20 minutes. And many studies have looked at this and analyzed that this is safe and that this does not increase the risk of worsening concussion symptoms, and as we'd mentioned, does help them return back to sport and life. And so with all of this, really a concussion treatment is really simple. Early, light to moderate aerobic exercise, starting somewhere after 24 hours after a concussion, 20 minutes a day. Physical therapists around here, there's many who manage concussions, and if you send a patient to them with the request to do a Buffalo or a concussion treadmill test, they can perform that and give the patient an idea of where they should be exercising. Or what I do most often is tell a patient to go out for a brisk walk, get on a treadmill and walk briskly, feel their heart rate, elevate a little bit, just a little shorter breath, and that's usually the sweet spot for most patients. Otherwise, concussion is just symptom management, and these are symptoms that you all deal with patients every single day. Concussions, we use over-the-counter medications. We use massage and cervical physical therapy and dry needling and trigger point injections if needed. There's preventative medications that in concussions, I refer to them more as abortive, because concussions, we just get this headache syndrome that we can't get out of. And so starting a medicine like amitriptyline or nortriptyline for a couple of weeks to a couple of months just to try to abort and get them out of that headache syndrome. There's vestibulo-ocular dysfunction with dizziness and imbalance that we can do vestibular therapy. We can use Zofran or other antiemetics if needed. This is a picture of a little handout that I'll often give patients to have them do their own ocular physical therapy at home, taping or putting Post-it notes on the mirror, and as they brush their teeth, just having their eyes go side to side and up and down, and kind of retraining their eyes to focus on objects. There's cognitive decline, where we have speech therapy and cognitive therapy that we can refer to help them through that. We can recommend short spurts as they're trying to get back to school and work of doing things like Sudoku and crosswords, word searches, just things to challenge the mind without having to go back to work or to school for 8 hours at a time. And there is some idea that potentially some omega-3 fatty acids can help with this. This is a study, not a real clinical study with patients, but from rats running through mazes after head injuries, and did show that they had improved function if they were on omega-3 fatty acids compared to those rats who were not. And so there's more research to come that potentially that can help with the neuroinflammation and regeneration from concussive injury. There's a lot of research out there going on. As I said, there's nothing else there that is ready for prime time. There's ideas that hyperbaric oxygen therapy, sensor deprivation, and floating in these water salt pods can be helpful. For prolonged concussion symptoms, there's vagus nerve stimulation that's being looked at, transcranial magnetic stimulation, neurofeedback therapy, cognitive behavioral therapy. One that I think is fairly interesting is the virtual reality rehabilitation. I think that'll become a big part of this going forward, and being able to put patients in a virtual reality world with moving objects and things to retrain that vestibular ocular system. And then there's potential lab markers and imaging and things that are coming down the pipeline to help us better diagnose and track recovery from concussions. And so kind of get into like what my basic practice is to try to make concussions as simple and easy so that you all, as you see them, we dread it a little less and we feel more comfortable and confident taking care of concussions. So I use this SCOTE tool every day with concussions. Mostly I use the first 3 pages of it, where I can get a big history of from the patient of concussion, of their comorbidities that may make concussions a little harder to treat because of medications or other issues, and then a symptom score. And I have them fill out that symptom score every time they come in to see me, so I can see how their symptoms are trending. And then if there's difficult to diagnose concussions or difficult to get back to sport, I use the rest of this form where we do more cognitive tests, kind of a little more advanced of a MOCA type test to see and pull out little small findings. I do VOMS testing where I'll look for ocular dysfunction. I'll do some basic balance testing in there to see that vestibular dysfunction. And then I try to first and foremost set expectations with the patients. Almost every patient who comes in to see me is frustrated because they saw urgent care or the emergency room 5 days ago, and they're there 10 days after their concussion and they're not better, and what is going on and why are they not better? And I try to set those expectations. I prescribe and give them strict recommendations of aerobic exercise at that first visit, as long as they meet those criteria I discussed. I recommend, at least in that first 48 hours, avoiding screen time, and then especially with the kids and the young adults who do a lot of screen time and a lot of social media. I recommend them getting back to screens that are required for work and school before they pull their phone out and start using that or video games or other things, and make sure that they're hitting the important things in life first. I make sure and discuss, do not get anywhere where you're going to get your head hit again. Potentially in that first visit, I may send them to vestibular therapy if there's significant imbalance. If they have significant cervical pain or dysfunction, immobility because of a head injury and whiplash, then I'll likely send them to physical therapy to start working on some of those muscles. And then I have them follow up with me about every 2 weeks. And then as they improve and we get further out and have more prolonged symptoms, once a month seems to be efficient for most of these patients. But that more frequent follow-up early on helps me to really not lose track of these patients and make sure we're making small little changes every few weeks to help them recovery. And then as they've had symptoms lasting more than 2 to 4 weeks, things like headaches that we just can't get rid of, then that's when I start trying some of these symptom-specific treatment options for them. And so, to me, I think concussion, like I said, concussion management is fairly straightforward and simple. I would recommend that wherever you are, whenever you see the patient, rather than recommending rest and saying just hang out and try as you can to get back into life, I would say go home and rest for a day and then start exercising and follow up regularly and track them back to full recovery. So I appreciate your time. I'm excited to be here and listen to the rest of what we have to offer today. Thank you.